So Chuck is a professor of economics at Northwestern University. He's been there since 1997, and he's been, previously he was at Wisconsin, he was at Hebrew University of Jerusalem, he was at Carnegie Mellon, and he got his PhD at MIT. He's written an amazing number of books. I'm like counting here, 1, 2, 3, 4, 5, 6, 7, 7 or 8 books, very, very impressive. He is an elected member of the National Academy of Sciences. He's an elected fellow of the American Academy of Arts and Sciences, the Econometric Society, on and on. He's got numerous awards. He's super impressive. His most famous article he wrote in 2004, which was with me. And so I had the pleasure of working with Chuck, and I learned so much from him. And then he's joined here. This work is joint with Aleksey Tetenov. And Alex is in Switzerland, right? He did his PhD work with Chuck. He got his PhD in 2008 with Chuck, and then he joined the Collegio Carlo Alberto. Where is that? Is that in?
It's in Turin, Italy.
It's in Italy, right? So
it's an economics center. Yeah.
Yeah, and then he went over to Bristol, right?
Yep.
And now he's recently moved to the University of Geneva in Switzerland. So I'm very jealous. I spent a summer in Switzerland, and it's unbelievable. So, Alex has been doing some amazing work. And so I'm excited to hear what Chuck has to teach us. He's going to tell us that we shouldn't really be focusing on hypothesis testing. He's going to tell us how we should be thinking about drawing inferences and making treatment choices, especially when it comes to COVID-19. So Chuck, I'll let you take it away. Alex will monitor the chat, and we will be try to be disruptive during your talk. So welcome.
Okay, thanks, Dan. Where were you? Somewhere in Utah.
So I moved. So I moved to Park City, Utah, and I'll be at a faculty member at the University of Utah. So I decided that I wanted to be near hiking and skiing and all that stuff. And but I miss my colleagues at Johns Hopkins, and I guess with COVID-19, right? It's we wouldn't see each other in the hallways anyway. So I still hang out with them on Zoom all the time. So
okay.
Anyway,
okay.
Welcome, Chuck.
Thanks, Dan. So Dan mentioned Alex and I will argue against use of hypothesis testing. That we're certainly not unique in that. And I suppose that most all of you know about all the ferment about hypothesis testing from multiple perspectives over the past 15 or 20 years. And in particular, that the American Statistical Association, had a committee to look into it and put out a statement in 2016. And then there was which is a kind of it's a committee statement, so people's views were all over the place. And then there was this important special issue of the American Statistician just last year in 2019. Alex and I have a paper in that special issue. I had another one on my own there. So there's a lot of background for this. Let me just talk a bit about the specific background for this work before we get into the particular paper. So I've worked on analysis of treatment response now for about 30 years, and particularly focused in the 1990s on situations where you have weak assumptions and you get what we call the partial identification in the econometrics literature. Around 2000, I started to think seriously about why do we do analysis of treatment response? And of course, some people say they do it because they want to do causal inference as a scientific matter. That's never been my own motivation. I've always thought of analysis of treatment response as a very practical question. And the reason you do it is you want to inform decision making. So I began to try to think formally about the use of results on treatment response, standard statistics like average treatment effects and so on, to make decisions. And once you start doing that, you immediately wonder why anyone uses hypothesis testing to make decisions. And this is particularly so in the medical literature, that hypothesis testing is very, very entrenched. It's entrenched in FDA rules for drug approval, and it's entrenched all over the place. And we'll see it in some of our slides. So it's not new, actually, to criticize hypothesis testing for decision making. Bayesian statistical decision theorists, Bayesian biostatisticians have been doing this for a long, long time from the Bayesian perspective. So I could have gone the Bayesian route and try to do applied work from the Bayesian perspective. And I want to say up front, I have no objection to that whatsoever in situations where the prior distribution really comes from somewhere, where you really feel that you've got a good reason to have the prior. Now, I have, on the other hand, I have a very strong distaste for doing Bayesian analysis with so-called convenience priors, or standard conventional priors that people use, whether they be so-called non-informative ones or this or that. Because as everyone knows, the prior that you use makes decisions, it affects the decisions that you make. And I don't like resorting to asymptotic analysis, which might say that the prior doesn't matter asymptotically, because we really are concerned with finite sample problems, sometimes quite small sample problems, and particularly with these COVID trials, the samples are pretty small. So I don't want to do asymptotics. So what am I going to do? So I'm old enough to have learned at one point, not directly from the source, of course, but I did learn about Wald's statistical decision theory way, way back. I learned this when I was an assistant professor at Carnegie Mellon, and which is a very strong Bayesian statistics department, but with a very strong emphasis on statistical decision making. And I said, well, let's apply Wald. And of course, you could apply Wald and put a prior on things and do Bayesian work, but I wanted to stay away from that. And so I wanted to look at decision criteria without a prior. And Wald, in his 1950 book, the seminal 1950 book, he emphasized Minimax for losses, or maximum for thinking about trying to maximize gains. There's a long, history on that, and concern about conservatism of the maximum criteria. I got taken quite early with the Minimax regret criterion, which was first proposed by Savage back in 1951 in JASA in a book review of Wald's book. And I started playing with Minimax regret. Now, there's a lot of stuff that we could talk about sort of conceptually and philosophically about distinctions between Bayesian and Maximin and Minimax regret decision making. And in some of the discussion, we can go into that if we want. For me, it was fairly pragmatic. I just wanted to see how Minimax regret had a kind of intuitive appeal to me, and we'll talk a lot about that, through the slides as we go on. And I wanted to see how it operates, and it seemed to operate pretty well. So the very first major paper that I wrote on this slide is this one in Econometrica in 2004 on statistical treatment rules for heterogeneous populations. And so this is all stuff that was showing up in the econometrics literature at first, not so much in the statistics literature, although Alex and I had a paper in the JSPI, Journal of Statistical Planning and Inference, back in 2007. So I'm going to skip, I'm not going to go through all that literature. There's been a whole set of papers that have been written mostly by econometricians over the past 15 or so years. So I want to go to the two immediate precedents for the current paper. One is the 2000, and these are both now joint between Alex and myself. One in PNAS in 2016 on sufficient trial size to inform clinical practice. And this is it's a technical paper. It has a very specific question, which is, I'm sure most everybody who's listening in here knows this well, is that if you're designing a clinical trial and you have to decide what the sample size is going to be, and particularly if you're going to go try to get a grant from NIH, what are you going to do? They're going to ask for a power calculation. And so it's going to presume that you're going to use the data to do hypothesis testing, and then you want to get sample size high enough to get type 2 errors down for some specified alternative. And power calculations come directly out of hypothesis testing, because hypothesis testing, I think, doesn't make much sense for decision making. I thought, well, that's not the way to go. And Alex and I said, so let's look. So what Alex and I did in this PNAS paper is he said, let's think about choosing sample size in a absolutely classical randomized trial. No validity problems, perfect internal and external validity, and say let's look at that in order to get sample size that will be good enough to get close enough to optimality in well-defined sense, and close enough to optimality is formally is another way of saying to get maximum regret down to a certain level. So I'm going to explain this later on. Now I'm going to give this whole talk verbally. We've got there's all the math in the technical appendix to the paper, and I've got slides at the very end of my slides here. But I think it's going to work best just to go through all this through tables and discussion, rather than try to lay out all the abstract notation. But of course we can do that to the extent that anyone wants to, and to the extent that there's enough time. So the PNAS paper in 2016 is like the big immediate precedent for the current work. And then the more recent one is the paper in the American Statistician on trial size for near optimal choice between surveillance and aggressive treatment. There's an application to a particular randomized medical trial on something called lymph node dissection, which I don't have to go into now. The innovation in the American Statistician paper is that we were interested in medical treatments where there were two important outcomes. This is kind of a primary outcome and a side effect. And there's always been a big problem in the medical literature about this asymmetry of you designate a primary outcome and then a secondary outcome and the side effect, and they're just treated very asymmetrically in the analysis. And we wanted to treat the so-called primary outcome and the side effect in a symmetric way, and that's what we do there, and that's going to show up here with the COVID trials. I'll give examples in just a second. So anyway, that's the background for this. Now, COVID, okay, so Alex and I have done this work. We've been trying to disseminate it for a while. And then COVID comes along and comes up with like perfect examples. Because if we think on the one that's on this slide here, this is quite early now. It seems like it's only a few months ago actually, but things move so fast with COVID that it seems now like a long time ago. This was one of the earliest major papers published. Cao et al. This is in China, based on early Chinese data, and it's a two-arm trial of severe patients with severe COVID in the hospital, and one arm is what's called standard care, and this notion of standard care is going to be important. And then there's going to be an innovation is to add to standard care a particular experimental drug combination, lopinavir, ritonavir, or however it's pronounced. So so it's a fairly small trial, and it's basically balanced. There's 99 patients who get the innovation, standard care plus the experimental drug, and then 100 patients who just get standard care, and then they measure outcomes up to 28 days after randomization, and it's boom, immediate publication in the New England Journal as early as 18th of March of this year, which is pretty early by COVID standards. Okay, so what I want to do is see how the results were reported in by the authors, and then how they were used later on. And Alex and I are going to argue this doesn't make a lot of sense to us. So here's formally the way the results were reported. They talked about a primary outcome and a secondary outcome. What they called the primary outcome was for patients who survived was the median time to clinical improvement. Was when did they start doing better in the hospital? And they found that the new treatment was a bit better. That the median time to clinical improvement was shorter by 1 day than with standard care. And so you see the statistics up there, the hazard rate, and the confidence interval is 1 to 1.91. So it's it's kind of marginally, it's a question of whether it's statistically significant or insignificant, because it's exactly 1.00. I'll tell you how it got interpreted. And then they said a secondary finding which Alex and I would actually think should be what we think of as a major finding, not secondary, which is mortality. And they wrote it down. This is a quote, that mortality was similar in the two groups. The question is if you're a clinician, not clear that this would be similar. It says the new drug treatment did better. It's 19.2% mortality versus 25%. In actual raw numbers, 19 out of 99 people died with the new drug, and 25 out of 100 died with the standard care. So Alex and I, of course, are not MDs, but if I were looking at that, I say, well, this is, it's not great, but the drug is certainly not hurting, and it may be doing a little bit of good. That's not the way that the authors reported it. What they reported, and this is a quote, is, so this is, if you're reading the abstract as a clinician in the New England Journal, this is what you're going to focus on. No benefit was observed with lopinavir/ritonavir treatment beyond standard care. Okay. Then there was an NIH panel that went further and actually recommended against it. Okay, so there's nothing in the data in the trial that says this thing is worse than standard care. There's some small evidence, depends on how you view it, that it's a little bit better. But the NIH panel reviewing this says that this lopinavir/ritonavir was studied in a small randomized trial with negative results. So what they call negative result is what I just gave you, which does not look to Alex and me as negative results. And then they said there was no difference in primary outcome, and 28-day mortality was similar. So the question is, what's going on? Is why are they, no one is saying that this is the wonder drug, but why are they so negative about this? And it comes directly from the standard use of hypothesis testing. Because in hypothesis testing, you make standard care, you make the null hypothesis on the test that the new drug is no better than standard care. And the alternative is that if you're doing a one-sided test, although they do two-sided tests for reasons that are somewhat obscure in the medical literature, but the interesting alternative is that the new drug is better. And as we all know from hypothesis testing, with the way things are done conventionally, there's a very large asymmetry in favor of the null hypothesis. Because if you look at standard practice, which has just been embedded in the literature since R.A. Fisher, kind of an offhand way suggested it so long ago, is that you want to have a 0.05 probability of a type 1 error. And then, of course, you care about type 2 errors as well. But the very strong convention in the medical literature has been you'll accept a larger probability of a type 2 error, and a considerably larger one. So there are all kinds of documents that say that it's okay to get a 0.2 probability of a type 2 error. Sometimes they'll say 10% to 20%. I've never seen anyone try to get the probability of a type 2 error down below 10%. So the literature, the whole way that hypothesis testing has been done is it makes things very asymmetric in favor of the status quo. And in fact, even if you think about the terminology that's used, is really strange if you think about COVID, because we talk about standard care versus an innovation or experimental drug. So, and in COVID treatment, the word standard care has become used routinely. But this seems really odd, particularly for COVID, because this is not a disease that's been around for 200 years. This has been this is a brand new disease, and there basically is no standard care. There is no years and years of clinical trials and observational data and so on that legitimate something to be called standard care. Standard care for COVID just kind of popped up out of nowhere. Again, I have to make a disclaimer that I'm not an MD, but I think all of us, we're so enmeshed with COVID. I think we know these things. Is they say, well, what's COVID? It's coronavirus. What do we know about coronavirus? It's not too much, but maybe it's like the flu in some ways, and maybe it's not like the flu. And so some kind of regimen popped up as a standard care without much basis. And then you have this great asymmetry in favor of standard care. So what goes on with hypothesis testing is, one, you have this huge asymmetry between that in favor of the status quo, with whatever is called standard care. The other thing about hypothesis testing, which is really bad, I think, and again, it's not original to Alex and myself. Bayesian statistical decision theorists, Bayesian biostatisticians have been saying this for a long, long time, is that hypothesis testing only cares about error probabilities and not about the magnitudes of errors, not about the size of the losses that you make. Now, that's going to be okay if the loss for making a type 1 error and a type 2 error is symmetric. But there are many cases in medical treatments where there's very asymmetric losses, in terms of patient health and so on. So hypothesis testing just doesn't do these things. So how should we do it? So I have on this slide this question: how should we measure precision of a trial? And formally, what maximum regret is exactly what's written on the slide, is the maximum expected loss in patient welfare for a treatment that's chosen based on a trial relative to the unknown best treatment. So let me get behind that for a bit. If you knew, let's imagine an ideal case is a kind of what statisticians like to call an oracle, so that you actually know what the truth is. And let's just say the mortality, for example, is what you care about. So if we knew what the mortality rate is for standard care and for the experimental drug, and then if we make and then we would know which one is better. And then if we choose an inferior treatment, let's make either a type 1 or a type 2 error, there'd be some loss that would be suffered. It would be the loss of a patient dying rather than living. Okay. Now, that would be the loss if that would happen. Then what's expected loss? Well, of course, the trial, you're basing whatever you do on the trial evidence, and the trial's coming from random sampling, the randomization of people into the two treatments. And so we have an expected loss across repeated trials, okay? So there's ordinarily sampling across trials, frequentist loss across trials, because if the trial outcomes are one way, you may put people in treatment A may look better. If they come out the other way, maybe treatment B will look better, and so on. So that's expected loss. And so obviously you'd like to minimize expected loss. Expected loss is what's called regret formally in the literature, okay? But we want to go back, and no one knows exactly who first used that term. Sometime between Savage in 1951 and in 53, 54, the term regret came into literature, and I've never been able to pin down who first used it, but that's what it's been called. But you can't minimize regret. You can't minimize expected loss because you don't know the truth. Obviously, if you only have sample evidence, you don't know what's the better treatment and what's the worst treatment. So you have to look across all possibilities. So what we do is we take the agnostic situation where there's a binary outcome. So it's a Bernoulli probability of death versus survival. And you have two of these Bernoulli probabilities. What's the probability of surviving with standard care? What's the probability of surviving with the new treatment? And those are two parameters that you don't know. And since you don't know what the truth is, you look at maximum regret across all possibilities. Okay, now this is exactly where what Minimax regret and the kind of work that we do differs from Bayesian analysis, because what a Bayesian would do is you'd have those two Bernoulli probabilities of survival or mortality under the two treatments, and would put a joint prior distribution on. Okay, and then a Bayesian would go with that joint prior distribution. So what we don't want to do is to put the prior on, because we're concerned about situations where you don't have a good basis for putting on the prior. Okay. Now again, we could go off for hours on whether it's sensible, when it's sensible or not sensible to put on priors. The only thing I want to just to shortcut that, even though it's been argued for so many years in the literature, is just to say that this question has not been resolved even now in 2020. Okay, that Bayesians, some people are kind of very strong Bayesians. I mean, you've left Hopkins, Dan, but I used to deal a lot with Tom Lewis, who I don't think is on this call now, but Tom would take a very strong Bayesian position, sometimes at least. And sometimes someone like Don Rubin may take a strong Bayesian position, other times he wouldn't. But it's always been controversial as to what prior to put on. And there's been, there's really no consensus on this.
So Chuck,
yeah,
can I interrupt?
Absolutely.
So we can feel like we're in an econometric seminar or economic seminar. So I know you're being very expository here. and you're trying to like stay away from the mathematics. But can you say a little bit about the loss function? Because obviously that's a critical component of what you're talking about.
Yeah.
Because we need that in order to define regret.
Absolutely. And this is not a distinction between regret and Bayesian work is either.
Sure. I know Bayesians have loss functions too.
Yeah. In fact, this is okay. So this is actually quite interesting historically, from our perspective, and also the perspective of Bayesian. You want to be very explicit about the loss function. And in the binary case of like mortality, the loss function is going to be, let me put it as a welfare function, because I'm going to talk about gains rather than losses, is you want to maximize the survival rate. That'd be like the very simplest one. You just have a binary outcome, you want to maximize the survival rate, okay? Now, in the initial things that we do as we go on, we'll just talk about that very simple binary outcome. The treatment is either a success or it's a failure. If it's a success, it's a 1. And if it's a failure, it gives you a 0. And then and what you're going to look at is across the whole population. So if you look across the whole population, because this is basically a population health rather than an individual clinical decision problem, you want to maximize the probability of success.
So you're going to assume at the end of the day that every patient will get the winning treatment.
Well,
right?
no.
So there's not.
No, absolutely not. In our work, in the whole literature in which I've been working in, you allow for total heterogeneity in treatment responses. So if the survival probability is 0.75, then that means that 75% of the patients live and 25% die.
I understand that.
Yeah.
But at the end of the day, if you have A versus B, treatment A versus treatment B, right?
Yeah.
And let's say the survival experience for people assigned to treatment A is 75%.
Yeah.
And it's 25 and it's 50% for treatment B.
Then A is better.
A is better than B, but at the end of the day, would you be assigning every patient would take in the future world would take A? Or
Okay.
are you making individual level treatment rules?
Okay.
Does that make sense?
Yeah, it makes absolute sense.
Yeah.
The initial discussion that we'll have here will be, we're going to say, that's okay, good question, right? The initial setup will be of a population of patients who are observationally identical,
okay.
but only observationally identical. They may actually be totally heterogeneous, but you can't tell one from another. And so we can only, when we actually come to make, if you think about a public health planner making the treatment decisions, there's no way to discriminate among them. Now, as we get late towards the end of our slides, we'll see that we may have observable risk factors that you want to separate patients, observable covariates, and you may want to systematically treat people differently on their covariates. So I'm going to leave, this is only for exposition. We're leaving out the observable covariates at the beginning. At the end, it becomes very simple to add in the covariates, because then you do just standard subgroup analysis. And you take so if you think about COVID patients, for example, treatment effects may vary with age. They could vary with race, who knows? They might vary with gender, they may vary with comorbidities. These may be all things that a clinician could observe. And then you would divide patients up into subgroups based on everything that's observable. And then you could make systematically different decisions for each subgroup. Now,
sure. So I want you to get to keep moving, but obviously if you've got a trial with 100 patients in each arm, right? Ultimately, you're going to get down to a situation where the subgroups are, super small, and you won't be able to say anything within a particular subgroup, right?
Yeah.
So,
And if you particularly if you have a continuous variable isolating the subgroups, and you have no prior information about commonalities in treatment response, this is not going to work. You'll have basically zero.
Exactly.
It's the usual cell size problem. I mean, we can't make magic, of course, but the problem of cell sizes, still persists no matter how you're doing things. So that's, maybe we can come back to this.
Let's keep going. I apologize. Keep
going.
No,
it's not a problem, because there's a lot.
No, because I want you to get through it, because I want to learn.
There's a lot to say about that. the only thing I'm just kind of jumping ahead to something that's in a slide towards the end, but since you raised this question now, I'll answer it right away. This also is an issue where hypothesis testing gets in the way, because Dan, I'm sure you and everybody else knows that there's been a strong convention in the biostatistics medical literature to only report subgroup results where you can have sample sizes that are big enough to give statistically significant results. And so there's a lot of subgroup analysis that could be reported in journal articles, but is suppressed because they view the sample size as too small. Now, obviously, sample size can be so small, like 0, 1, that you don't want to waste journal space reporting that. But Alex and I think that there's a lot of subgroup analysis that could be reported and would be useful to clinicians, but does not rise to the level of statistical significance. Okay, so that's where hypothesis testing comes in there. Okay, so let me go on. So,
I think that's a misrepresentation of the biostatistics community. I mean, I've done many trials. I don't think I ever only report subgroups on things that where I know I can get a statistical significant finding. So, but and Betsy, please.
I'll call it a characteristic of the medical literature.
Okay, fine. Go ahead, Betsy.
I have a related question, but if you're going to come to this, feel free to put me off. Sure. Even before you consider diving into subgroups, if after this 200-person trial, the standard of care had become leponavir, ritonavir, then we may never have gotten the higher quality evidence that we would need to know whether that really deserves to be part of standard of care. So is that part of your decision-making framework?
Not in this paper. It's in the very, that question is raised on the very last slide as a direction for future research. And it's one, again, I don't mind jumping back and forth like this, because let me take the question when it comes up. We'll save the time later on. This has been a question that's been bugging Alex and me quite considerably. That I think what you're alluding to is that actually in the real world there's a dynamic process where a trial is run and you learn something, and something might have been called standard care before, but then as a result of what you learn in the trial, the definition of what standard care is changes, and there's actually a whole sequence of trials where the definition of standard care changes. And so for hypothesis testing, the null hypothesis changes over time. And that's a kind of to me as a non-medical person, it's a kind of mysterious process of how the definition of standard care gets changed over time. We, in the very conclusion discussion part of our paper, we raised that question. We don't formally have anything to say about it in the paper because we think it's very important, but it's a very tough and basically totally unstudied question. And the point I want to make, let me just add one thing and then I'll give it back to you, is that in the classical way of reporting results in the medical literature, there is no discussion of that at all. I mean, MDs are not stupid people, and the MD medical researchers, they may have that in the back of their heads. But if you look at the standard protocol for doing hypothesis testing, it's just one trial at a time in isolation. And so that whole dynamic in the background is just, as far as I know, as far as Alex and I know, is totally missed in the current way of doing things.
Yeah, that reminds me of some work in the observational causal inference world about natural definitions of treatments, where there's a word that is meant to describe a condition, but it's actually a conglomeration. It's a mixture distribution of lots of different precisely defined treatments. But that's actually what I meant was something slightly different, which is, do you have to achieve a certain level of evidence before you would recommend changing practice? So I thought that what Dan's question was going to point to was not subgroups, but rather, if you think that the evidence is medium strong towards using lopinavir, ritonavir, would you recommend a regimen going forward where it's given more often than not, but in such a way that you can accumulate more principled evidence either in favor or against it?
Well, okay, there's a couple of things on what you said. The words that you use, would you change standard practice? What we're going to be suggesting is get rid of the whole notion of standard practice. particularly in a case like COVID where there's no, if I just call the two treatments, treatment A and treatment B, they're just labels. And there is no such thing as a privileged position for standard practice. You just treat them symmetrically. And that's what we're going to do. And we're going to be, what the formal analysis of the paper, what this whole set of papers that I'm talking about is looking at, you just got one trial, it's been done. Maybe in the future you could collect more data, but that would get into the dynamics that we're talking about, where, you know, I just mentioned, on which there isn't the formal literature yet. It's just, you've got this trial, you've got to just make a decision today. So I think that the way to think about this is, imagine you're a clinician on March 18th, 2020, who's just seen the results of the Cow et al. Trial with 100 patients in the 99, and that's the data that you've got, and you're treating some patient in the hospital right that day, and you've got to make a decision on that day. Okay.
Isn't that what happened with hydroxychloroquine? I guess that trial, the Didier Renault trial, was probably wouldn't survive your analysis, but it seems like sociologically, that's kind of what's happened for COVID in a lot of respects, with convalescent plasma, with hydroxychloroquine, and it hasn't gone so well.
I don't think that was by any means a randomized controlled trial, what happened in Marseille
okay.
with the Raoult. So I think they were not randomized to treatments, first of all. It was a trial. It was a 2-arm trial, but it was explicitly non-randomized.
Mm-hmm.
So I think when we started this on March, we actually basically picked the best example of an actual RCT, which measured sort of real patient relevant outcomes. And at that point, actually, this cow trial was the largest one available.
Yeah. So let me, it's actually on this slide on exactly what we do. And I hope I'm trying to make it's a kind of fairly limited context. You've got the data from one trial and you got to go with it. But that is the context in which the medical profession operates. That is like in that NIH statement that I just had up on here, the NIH panel here, that's exactly what NIH was doing, that they made a recommendation just based on that. So I think there's a lot of issues behind that Alex and I feel uncomfortable with. We're only focusing on the one as a use of hypothesis testing versus something else. So let's go on to see what we do. So instead of using the two-sided hypothesis test, which is the standard, we're going to argue for it's so simple. We just have to give it a name. It's the name I've used since for the last 20 years. It's called the empirical success rule. Just look at the trial, particularly think about a balanced trial, which is where this is simplest, so it doesn't have to be balanced. Let's say you got the same number of people in both treatment groups, and you just look at which one does better, period. And if hydrochloroquine did better in the trial, and if it were a real randomized trial, we would say, yeah, go with that. Because there is no such thing as standard care that should be given a privileged status. This is just treatment A and this treatment B. So if you do better in the trial, you know, if the average treatment effect is positive, you do one thing. If the average treatment effect is negative, you do the other thing. It's what the layman would most obviously do, and you don't pay attention to statistical significance. The other thing that we have here, which is a side point that we think is so important that we put it with an exclamation mark, is that when you measure outcomes, you want to measure the outcome that really matters to patients. And this distinction between primary outcome and secondary outcome in the medical literature, which is sometimes it's made from the patient's perspective, but sometimes it's made basically from a perspective of other things, you know, which I can't get into medical researchers' head as to how they designate something primary and how they designate something secondary. We don't want to do that. If you think that there are two outcomes that matter, let's say on the cow trial, you care both about mortality and about time to recovery, then you may want to maximize a welfare function that takes into account both of them, okay? So we do that later in our paper too. It's in the biostatistics medical literature, it would be called the composite outcome, okay? But you take the composite outcome, it might be some weighted average of the results on all the different parts of the vector of outcomes. So this is what we do. This is the empirical success rule, okay? So it's extremely simple. Let's put this through. in the simplest case of a two-arm trial, this is exactly the cow et al. Trial. Two-arm trial, almost balanced, 100 patients in one arm, 99 in the other. The only difference that I will make is that we'll take that the outcome you care about is mortality, not time to recovery. So let's just, this is hypothetically, since you don't know the truth, let's imagine that the mortality rate, we got this, yeah, this is a typo from let's imagine well, the actual observed mortality rate was 0.25. So this is a typo I see on the slide now, that the mortality with standard care is 0.25, not 0.75, just change that. And let's imagine that with the new treatment, with the drugs, it's one of these possible mortality rates. So then you just imagine different scenarios where the mortality rate with the new drug may be worse or may be better than with the standard care. This stuff in pink, this is, now you're going to use the standard t-test rule. And this is the fraction of trials after which standard care will be prescribed. Now, in these cases here, these three to the left, standard care really is better. And so this is actually this is the probability of getting it right. This is 1 minus the probability of a type 1 error. And they'll be extremely high, okay? These things are the case where you get it wrong, where you're going to choose, where you choose standard care, but actually the new treatment is better. So those are type 2 errors, type 1 errors, because the mortality rates really are lower with the new treatment. And here's the probabilities of making type 1 errors in those two cases, 80, whatever. Take this case here, 0.15. So the new treatment is really considerably better, much lower. The loss from choosing standard care, standard care is 25% mortality. New treatment has only 15% mortality. And so you're going to make a type 2 error and lose 10% mortality with probability of 0.5736, okay? So these are the probabilities of type 1 errors. Symmetrically over here, these are—
So sorry, Chuck, how did you compute the 0.05 and the 0.1? What is that? Sorry, I missed that.
Oh, because this is a scenario in which the mortality with standard care is 0.25. Mortality with the new treatment is 0.20. And the difference between 0.25 and 0.20 is 0.05.
There's actually a typo in the slide where it says the mortality rate with standard care is 0.75. That should be 0.25.
Yeah, that was I said that was the—
Sure, and then the zeros here, what are the zeros? Sorry, if that's, I understand.
There's no loss because you choose the regret 0.
Got it, okay.
In these cases here, standard care is actually better than the new treatment. Because remember, again, it's not 0.75, it should be 0.25. In all these three cases here, the new treatment is actually worse, so there's no loss from choosing standard care.
Oh, loss from choosing standard care. Okay, sorry, go ahead.
So this is actually the loss function. So the loss function is the difference in average outcomes.
Right.
Between the best and the one implemented.
Yeah,
Okay.
and in these three cases here, there's no loss because you choose the right one. In these two cases where you would make the mistake, you committed, this is a type 1 error, this is the magnitude of the type 1 error, okay? And which is right here. Now, if you look down here at expected loss, right down here, the 0.0434, let me see if I can do that. What's 0.0434? It's just the 0.05 times 0.8676. That's all that is. Okay, so this is the probability of a type. This is put in percentages, make it into probabilities. The probability of a type 1 error is 0.8676. The loss when you make a type 1 error is 0.05. 0.8676 times 0.05 is 0.0434. Okay, so if you were in that world where the new treatment is actually better by 5 percentage points in mortality, and you make a loss, if you were using the t-test, there'd be a very high probability of type 1 error, of course. In that case, then the expected loss would be 0.0434. The 0.05774 here is the same thing. It's just 0.1 times 0.5736. okay? Now that's the case where the result of the test, the way the numbers come out in the test is that you make type 1 errors. Of course, because it's repeated sampling in a randomized trial, the data will come up the other way sometimes, so you'll reject the null hypothesis. So here are the cases, when I say percentage of trials after which new treatments will be prescribed, these are the trials, because remember, we're doing repeated frequent sampling. There'll be some trials in which you reject the null hypothesis. The probabilities of that happening are going to be very low because of the asymmetry. They're only 2%, extremely low, 0.3%, very, very low. The losses will be symmetric in those cases, 0.1 and 0.05, because the mortality rate with new treatment is 0.35 rather than 0.25. Those expected losses are extremely low, okay? So that's what you get in these different scenarios, okay? So that's what's on the table. It's like saying, let's imagine the probabilities of this and this, then what would happen? Okay, now that's not the real world decision problem. The real world decision problem is you don't know what the mortality rate is or standard care is. So you don't, again, this is 0.25, you don't know that it's 0.25. And you don't know what the mortality rate is with new treatments. We don't know if it's 0.35, 0.30, 0.25, any of these numbers. It can be anywhere between 0 and 1. So Bayesian would put down priors in these things. We don't put down priors. We look at the maximum. We just look at these do these expected loss calculations across all pairs of Bernoulli probabilities. So this is what in the algorithm that we programmed up. This is just brute force computation. You just do a grid search. You divide up all. You get 2 Bernoulli probabilities. You take a very fine grid. You do the calculations of these things. It's all based on binomial probabilities. So this is pretty simple to do. You just go to the computer and you do it, and you find out that what we call the worst state of nature, the one where you get maximum loss, is where the new treatment has mortality rate 0.548 and standard care has rate 0.661. That's the case that's worst in terms of expected loss.
So Chuck, where's the data coming in here now? Just tell me how the data from the actual trial is coming into play in these calculations.
The data from the actual trial is not coming into play, and this is because this is all an ex-ante calculation of across repeated trials. This is no different than what we do with hypothesis testing. And you have to remember so let me just say, I've mentioned Bayesian before. You have a Bayesian perspective of doing conditional analysis and going from a prior to posterior after seeing the data. But let's remember the most basic aspect of frequentist statistics is that we do all of our evaluation of everything ex ante before seeing the data. So when in hypothesis testing, I have to keep this in mind myself. So I'm not surprised that you asked that. I have to keep, even though it's totally embedded in frequentist statistics, I have to keep reminding myself. We're asking across repeated samples what will happen. So when we talk about an error probability or type 1 and type 2 error probabilities, those are calculations done before seeing the data.
Okay, I guess the sample size comes into play here.
The sample size comes into play, yeah.
But not the actual data observed.
But not the actual data. Yeah.
Okay.
Because what would happen when the higher sample size, and the next slide is actually going to show that. But this is for this particular sample size. Sample size definitely comes into play. And of course, it doesn't power calculations with testing. It'll come into play in a different way with us, but not the actual data. And so what we're getting here is an expected loss of 0.6, the loss is going to be 0.661 minus 0.548. That's the loss you'll suffer when you make the wrong decision. The error probabilities, and these are calculations that we had to do. They're not shown on the slide. This comes out of our programmed algorithm. It's 0.624. You multiply 0.624 times this difference, which is a little bit more than 0.1, and you come out with 0.071. So this is maximum regret or maximum expected loss with the t-test. Okay, so keep this number in mind, 0.071. Now I've got the one more slide, which is doing the same thing with the empirical success rule. And the empirical success rule is not asymmetric. It's not deferring to the status quo the way that hypothesis testing does. It's just going to if the average treatment effect is positive, you're going to pick the new treatment. If it's negative, you're going to pick the standard care. You do exactly the same calculations. The numbers now look entirely different because you're not deferring to the status quo. These are your probabilities of type 1 errors. Sorry, type 2 errors over here now. These are exactly the same calculations. Let me just go through this quickly, but just using the different treatment rule. Here's the same thing with the treatment will be prescribed. So these are the probabilities of type 1 errors. Remember, before the probabilities of type 1 errors were almost negligible because things were being spun so much in favor of standard care. Here you're getting smaller probabilities of type 2 errors and larger probabilities of type 1 errors. Again, we go through all those things. These are just the particular scenarios, but now come to maximum expected loss again. And here, the bottom line is that maximum expected loss is 0.012 as opposed to 0.071. So it's like basically 1/6 the size of, you're reducing maximum expected loss to 1/6 the size that it would have been with hypothesis testing. So that's a really non-trivial difference. Okay. Final slide on this set before we go on to multi-arm trials. Let me. I missed it. Oh, okay. Let me just skip to this. This because you talked about the sample sizes. This is basically the cow trial. It wasn't 100, it was 199, but that's pretty much the number I showed, the 0.012. Now let's do this for different sample sizes. The degree of near optimality or the level of maximum regret, if you just look at this, it actually goes down in the standard way. It goes down with the square root of the sample size. So so that kind of intuition that we have in general statistics, that things get better at a square root of n rate. And you can prove this formally in terms of the theory.
Sorry, what do you mean by near optimality here, Chuck?
The term, when I talked about maximum, we have this term expected loss. So we have an optimal treatment that you could choose, but you may not, because you make mistakes, type 1 and type 2 errors.
Yeah.
There's some probability of making a type 1 and type 2 error, and there'll be a loss relative to the optimal. So near optimality means how close do you get to the optimal? And so that's the term that Alex and I have been using. Near optimality is in the literature traditionally was called regret. So for years I would just say regret. I wouldn't use the term near optimality. I found, and Alex found in talking to more applied people, that the term regret gets them a little confused. And so we found it easier to just talk about how close can you get to optimal, because that's what regret is. That's what Savage had in mind. He didn't use either of these terms. Is how close do you get to optimal? How near to optimal are you? And of course, the sample size goes up in terms of this particular formal expected loss. The expected loss, maximum expected loss, is going to go to 0 relative to optimal as sample size goes up. And you can see how it drops with these sample sizes here. Okay, so we've just taken to using this term near optimal rather than regret because it just seems more salient if you're not embedded in the statistical decision theory literature. Okay, so that was that question, how sample size matters. Now, in terms of why do this, there's some theory behind that. These are all calculations that we were doing, but there is a substantial theoretical literature behind this, which has basically all been in the econometrics literature. So I started with my own paper in 2004. It's quite an important paper in the Journal of Econometrics by York Stoyer in 2009, and he proves that this empirical success rule is exactly optimal. It formally minimizes maximum regret in balanced trials with binary outcomes. And I really want to emphasize, these are exact finite sample results. There's no asymptotic theory that we're using in any of this. The Wald statistical decision theory was always an exact finite sample theory and not asymptotics. And that's part of why I really like it. Now, if there is an asymptotic version of it, Hirano and Porter in Econometrica in 2009, they did an asymptotic version. Now, if some of you, I don't know what particular statistical theory courses you had, this stuff is really out of fashion. Way back in the early 50s, Lacan and Hayek did very abstract asymptotic version of Wald, and which is kind of a really tough part of mathematical statistics. Hirano and Porter apply that in their Econometrica paper in 2009. Now, another paper that I really should mention here, except it's not in the direct flow, is if you go to Econometrica in 2018, then there's what I think I can say is a quite important paper by Tokugawa and by Aleksey that pushes all this stuff further. So this is like a very large technical methodological paper in 2018. This is all, again, it's in Econometrica, Journal of Econometrics. So I wouldn't be surprised if you haven't seen this stuff. It hasn't been published in biostatistics literature. Okay. So there's that theory behind it. You treat the type 1 and type 2 errors symmetrically. Hypothesis testing does it very asymmetrically. We go on. We argue strongly, particularly for COVID, that there's no conceptual, philosophical, clinical reason that we can think of to treat standard care asymmetrically. I'd rather just use the arbitrary labels, treatment A and treatment B. Because as I said at the beginning, standard care has been postulated for COVID, has been postulated without evidence that it's better than other options, okay? But once you've set standard care, it becomes, you have to overturn the status quo. That's what hypothesis testing does. Hypothesis testing is made to make it difficult to overturn the whatever the status quo is, so you could be stuck with it for a long time. Now, we have some other arguments here about clinical equipoise, which I think I'm going to skip. You can just read it on the slide and so on, but it will get us off in another philosophical debate about what clinical equipoise actually means in the medical literature, so, which I think is really interesting, but I think I'll just skip that. Okay, other issue is, which I've already mentioned will come, is that you may have multiple outcomes of interest. When hypothesis testing is done, it is done generally for the primary outcome. Sometimes it'll be done for the secondary outcome, sometimes not. There'll be a tertiary thing of so-called side effects, various other things that will be listed in a paper, but there won't be formal statistical analysis at all. And with the way we're doing it, this goes back to the question of the welfare function that Dan raised early on, because the welfare function is absolutely crucial, is that you want to apply the welfare function to what we think of. There may be multiple patient-relevant outcomes, and somehow you want to weight them all up as to how much does this matter, how much does this matter, and get some kind of an aggregated utility function or welfare function. And you got to decide what that is, okay? So in the initial stuff, just the binary doesn't come to play. But once you have side effects, then it certainly does come into play. And with COVID, this is really non-trivial, because some of these, well, first of all, COVID can have, just with or without treatment, as we're learning, has all kinds of like chronic disease effects that we're slowly learning about. And then some treatments can be toxic and have, and with the hydrochloroquine, the whole controversy was about having a bad side effect in terms of heart attacks and strokes, right? So those, they may not be side effects, they may be more important than the effects on the primary effect. So what we're doing with the empirical success rule is you want to apply it to a weighted average of all patient relevant outcomes. Okay, now I see, I want to keep on the time. What I've gone through here is just one final thing about the problems that hypothesis testing requires, particularly now thinking about sample sizes and power calculations. And I think, and we're seeing this now, particularly with the vaccine trials that are starting up over the summer, is in order to get sufficient statistical power by standard criteria, you may need quite large sample sizes. And that has multiple downsides. One is it takes time to recruit patients. So if you're in a kind of a crisis like we are now, You know, the number of patients that have been recruited for the vaccine trials is like 30,000 for one and 60,000 for another. And, you know, and that takes a while, and that's going to delay getting results from those trials. Second, since there's only so many patients who are willing to participate in trials to go along, patients for whom you can get informed consent, having larger trials crowds out other trials. So you can't, I mean, these are long-standing issues that every biostatistician is aware of. What we're saying is that if you move away from hypothesis testing and do things the way that we're suggesting, you can get reasonable results with far smaller sample sizes. I'm talking about sample sizes that are maybe a fifth or a tenth the size of standard sample sizes. So this could be quite important for clinical practice. So, and then you can't do all the subgroup analysis that we talked about before. You know, so we actually think this is not just a theoretical exercise, that it actually could matter a lot for clinical practice. Now, okay, now let's go on in the time we have. I'm going to take maybe 15 more minutes to go through the rest of it. I think you've got the basic idea now. I want to go through some expansions, some of which is formal analysis in the paper, and some of it is just, you know, discussion of things for the future. Is what's going on now? There's all kinds of trials going on for COVID, and most of them are two-arm trials, and they're like going on all over the world with different inclusion criteria, different PIs, and even different definitions of what standard care is. Because if you go from one trial to another, there is no, you know, total consensus clinical practice guideline on what standard care for COVID is. So if you try, so you run into, and also of course different study populations. You know, some people with severe disease, lighter disease, older people, younger people, on and on and on. So it's going to be very difficult to compare alternative treatments across trials, the way things are. Now, there is some good news on this. I mean, this is fine. It's a very decentralized process, and different investigators in different countries are doing different things. The kind of good news is there's a couple of trials that are, I think, you know, they're pretty exemplary in that they, at least in their intention, is to be multi-arm trials, which so that you would get the, so that you could do really comparison of multiple treatments across on a same study population. So one is going on in the UK. It's called the recovery trial. It started with 5 arms. One is standard care, and then we have 4 drugs. One is the slopenar-ritonavir. One is some steroids. We have our famous maybe Trump can pronounce it, but I can't. Hydroxychloroquine, since I'm not a stable genius, I can't pronounce it. And this other drug, now actually a couple of them have been cut since then, but they started off with a 5-arm trial, and this is the, it's imbalanced. It's towards standard care, that there's double the number of people in standard care. I'll explain why they did that in a moment. And then there's a WHO organized trial also with 5 arms. So these are nice ideas to have multi-arm trials. So now we can think about, well, how are we going to analyze multi-arm trials? So that's the formal statistical question now, is to how are you going to analyze multi-arm trials? So this is an old question in statistics. And what's going on in the recovery trial is something that I'm sure all of you who are statisticians or biostatisticians know, is Dunnett's test, which goes back to the 1950s. And what it does is it do multiple standard t-tests, but then you set up a, there's actually some kind of complications here that Alex understands better than I do about whether you do this as 2-sided test, 1-sided test. It's a little bit confusing to me. What we wrote on the slide here is that this is a multi-t-test procedure with type 1 error probability that at least one test yields a positive, statistically significant average treatment effect. The t-tests are done 2-sided, but the overall criteria is done 1-sided. Alex, is that correct? Alex, are you there? Why don't we?
Sorry, I forgot my mute button where it is. Yeah, more or less. Actually, the interesting thing in practice, 3 of the arms of recovery have been terminated now. The papers that they've published all analyze these as 2-arm trials. without actually any multiple testing comparison. So this is what was in the protocol, and this is actually what we modeled. It turned out not to be followed by the investigators themselves.
Yeah, yeah.
But we try to kind of model what they wrote in the original protocol as a statistical analysis.
So this is the version. Let me just do it quickly because we don't have time to go through the details. This is the version of hypothesis testing that was at least in the protocol, was to use Dunnett's test with the 5 arms. This is a table that's like the table I had before. I won't go through the numbers for a very specific scenario. And panel A says, what happens if you use the Dunnett's test and what kind of expected losses will you get here? Panel B says, what happens if you use the empirical success rule? It turns out the empirical, again, so we had to program this up. This was a much bigger computational problem now, because now instead of just having 2 Bernoulli probabilities, treatment A, treatment B, but we have standard care and then treatment A, B, C, D. So you have 5 Bernoulli probabilities. So it's and it's a 5-dimensional probability distribution, and you don't know any of these things. So this is a much bigger computational problem, and the details of how we did the maximum regret or maximum expected loss analysis are in the technical appendix of our paper. And but here's the bottom line: is that we did this. This is like this one table summarizes everything. You have a choice between using the Dunnett's test rule or the empirical success rule. We do this with different sample sizes here. The reason why we do it with different sample sizes is because the recovery trial, unlike the cow et al., they're still collecting patients, and they started reporting results as sample sizes continuing to increase. So we wanted to do this for different sample sizes. We maintained their 2:1:1:1 sample ratio through all these things. The main thing to do is, if you compare these things, is that using the empirical success rule, you do about 4 times as well as using the Dunnett's rule. 0.03 to 0.12, going down to 0.008 to 0.0274, basically between 1/3 to 1/4 is the size all the time. So across all these different sample sizes for this multiple arm setting, you do better. Now, finally, the question, why 2:1:1:1? Because it goes way back in a paper by Dunnett himself in 1962. He argued that for use of Dunnett's rule, there's a kind of heuristic that you should put twice as many people in standard care, and because it's not just labels, there really is something that's labeled as standard care, and as you do in all the alternative treatments. When we've done the analysis for the empirical success rule, we find there's no reason to do 2:1:1:1. It's better to use a totally balanced trial from the perspective of the empirical success rule. But it's only a slight difference. It's not bad to use the 2:1:1. Okay, I've just got a few more slides, so let me go on. Then we have a section of the paper which extends the results that I've talked about. No more tables, but it goes through verbally and with a little bit of math from our previous work in 2 directions. One, it could be multiple outcomes, which I've talked about before. It's not just a binary survival versus death. It could be multiple outcomes. A very simple case of that would be a binary primary outcome and a binary side effect. Okay, so this was, we did that explicitly in our 2019 paper, where we have the so-called primary outcome was survival. This was on treatment for melanoma, was the particular trial that we looked at. But in the particular treatment is something called lymph node dissection, where you do surgery to remove lymph nodes. And lymph node dissection, it's been very controversial for 100 years whether this thing works or not, but it clearly has a side effect, is that patients suffer from lymphedema. They get swelling in the area where the lymph nodes are removed. So there are 2 outcomes that matter. And so that's a very simple case. It's a very common thing of a kind of a binary primary outcome and a binary side effect. We know how to do the formal analysis for that. And we talk about that in the paper. And there also, there could be patient-specific effects, variation in treatment response by age, gender, comorbidities. and so on. We know
So
how
Chuck,
to deal with all of those problems. Okay.
so
Yeah.
Chuck, can I interrupt for 1 second?
Dan, go ahead. Sure.
So let's say that the world adopts your view about how trials should be analyzed and run.
Yeah.
Okay. And we move away from this hypothesis testing paradigm. Can you say how you would report? So let's say now you're the main person on New England Journal paper.
Yeah.
Can you tell me how you would report the findings and how uncertainty might be brought into play so imagine you're writing that penultimate paragraph, or you're reporting the results of a trial. How would you report them?
Well, it's right here, because the uncertainty is maximum expected loss. It's really, I think it's just, as I said, this is not my idea, it's not Alex's idea. This has been in the literature since the 1950s, except it hasn't been exploited. It's been buried. And
so I run this trial. I have 100, 50, 50, 50, 50 in each arm, right? And I just would say, what, treatment A had the highest success probability. Let's say we're doing binary outcome and it's mortality.
Yeah. And the expected loss would be this 0.0362.
And this trial, because your calculation of the 0.0362 has nothing to do with the data in the trial other than the sample size.
Exactly.
So you would just say, the estimate or the empirical probability of dying, you'd report it separately by each arm, each of the 2, 4, 5 arms.
Yeah.
And you'd say, whatever, arm C had the, best mortality experience.
Right.
And that this trial had the following operating characteristics in terms of maximum regret, or whatever, this near optimality thing. Yeah. And it was 0.0362.
Right, exactly. And that's actually parallels what happens today, because an average treatment, the mortality rate by arm will be reported, and then you'll report the probabilities of, let's say if it's a 2-arm trial, of it's the type 1 and type 2 error. If it's a hypothesis testing, you get the multiple.
Sure, but another way of characterizing uncertainty, right, is to report, confidence intervals, right?
Yeah.
Which do use the data from the actual trial in their computation.
Yeah, well, that's interesting. Yeah. It's a very, okay. I mean, there's so many things that we could talk about for, as I said, for hours and hours. Personally, I like confidence. I hate hypothesis testing. Personally, I like confidence intervals. When I do empirical work, I report them. We all know that there's no, you talk about a 95% confidence interval, there's no single best interval.
Sure.
We all know that stuff. Nevertheless, we have kind of conventions on shortest intervals or symmetric intervals or this or that. I particularly like finite sample intervals. For Bernoulli stuff, I like the original Klopper-Pearson from 1934, because even if it's an exact interval, no asymptotic theory, but those, fine. But the interesting thing is, in the Wald theory, the confidence intervals just don't show up at all. Mm-hmm. And it actually bugs me. And I keep trying to find, is there a role that confidence intervals play in Wald's theory? And I say Wald's, it's not just the Minimax regret, it's in Wald's theory entirely. Because you could do maximum, you could do base. I mean, there's no room. So what do Bayesians do? Bayesians have no room for frequentist confidence intervals too. Bayesians, of course, we all know, present posterior credibility intervals. Mm-hmm. But I view those as entirely different, because a posterior, I understand the Bayesian credibility interval much more as a summary statistic for a posterior distribution. I think I understand that more than I do a frequentist confidence interval.
Why can't you combine? Sorry.
What's that?
Oh, well, why can't you combine them? Like, couldn't this gives you the maximum expected loss, but then the confidence interval gives you a range of probable losses.
Yeah. Well, I'm not going to argue against reporting confidence intervals, because I have this gut feeling that they're useful. When I said that I don't know what to do with them, it means formally from the perspective of statistical decision theory. So if you want to report them as another statistic that you may find useful, at this point I won't argue against it, but I can't fit them into this theory. That's what I meant. In terms of going back to Dan's question about uncertainty, what's going to happen is uncertainty is going to go to zero as sample size goes to infinity. And these numbers right over here show that uncertainty goes to zero, 0.036, 0.025, 0.0, uncertainty goes down at rate root n. Just like confidence interval widths will go down at rate root n. And that's, in terms of the formal theory, that's how uncertainty shows up, and not in confidence intervals. I don't want, even though there's a small group of economists, let me just make a plea, totally separate from this paper. There's a small group of econometricians who've been working in this area. Alex and I have both done a fair amount of work. York Stoyer, who I mentioned, Kay Hirano, Jack Porter, and I could list probably just a few other people, no more. There's all kinds of open questions. And we would love to have other people, including younger ones on Betsy's screen, who may eventually do work in this area, maybe 15 years or so, judging by her age. There's just an enormous amount to be done. So to figure out exactly where confidence intervals fit in, I think is part of it.
Could I make a small point?
Yeah.
So the near optimality here crucially depends on how decisions are made after the results are announced. So what we're evaluating are decision procedures.
Right.
And so one of the problems with reporting confidence intervals is actually that makes it uncertain what the decision procedure is, right? So if I say the result of the trial is unclear and there's no recommendation, it's also unclear what will be done. So we know in practice, for example, that when the results are unclear that new treatments are not implemented, that's the convention, and then that allows us to model it. But if you kind of leave things open, basically it actually means that there's a lot of ways that results could be used, and that actually means that there's a bigger range of losses that could happen. And so the near optimality report is only for specific decision rules.
Yeah. Yeah, that's, let me just add very quickly a point on that.
Yeah, I understand that. Go ahead.
Yeah. But part of philosophically, I think why people like to do hypothesis testing is because they think they don't want to specify a welfare function. They want to do pure science, as they say, without specifying a welfare function. But we think that's impossible for decision making. If you're going to make decisions, you have to specify a welfare function. So it's kind of hopeless philosophically to think that you can do this. So that again is a kind of big conceptual point. Let me just to finish up. Okay, so I already talked about this. I won't go through the details. This is the case where you have the main effect and the side effect. And go read the 2019 paper in the American Statistician to see how we do that. The other thing, and this will be the final substantive thing, is everything I've talked about up to now has been with binary outcomes. Or it could be two binary outcomes, primary and side effect. Of course, sometimes you have discrete or continuous outcomes. Computationally, the kind of brute force computation that we do with binary outcomes is not going to work with the continuous outcome, because it's just a state space. It's like all possible distributions of a continuous outcome is really different than all possible binomial distributions, right? It's just a big non-parametric problem. But you can make progress, and this goes back to my original work, is that if you have continuous outcomes or any real valued outcome, as long as it's bounded, then we have a whole literature in statistical theory on large deviations and inequalities that are very useful for this. So one of the classical large deviations and inequalities is the Hefting inequality, which is in JASA in 1963. So I used the Hefting inequality to get upper bounds on near optimality with two treatments. And then in the paper that Alex and I did together in 2016, the PNAS paper, we extended that to multi-arm trials. And here you have a number of treatments. And we also did imbalanced trials, but the results are extremely simple when you have a balanced design, and you get upper bounds on near optimality that are these particular upper bounds. These are analytical upper bounds. These are conservative. This is not an exact calculation, but it isn't. It's a true finite sample upper bound, and you'd have to go read the 2016 paper to do that. To see that. That's just some of the literature that's in the background. Okay, now finally, okay, heterogeneous patients, already talked about at the beginning, just do subgroup analysis. Okay, this is the final slide. And it really, I think, shows how much there remains to be doing. Because I tried to, full disclosure, I said this at the beginning, we've considered treatment choice using data from one trial with full validity, okay? So if you think about all of the, and that's exactly what the hypothesis testing literature has done, is doing a classical trial, one trial at a time. But if you think about all the things that are more complicated in the real world, one, of course, is issues everybody knows this, so I just got a limited internal validity, you have non-compliance, loss to follow, external validity, measurement of surrogate outcomes, differences between study populations and treatment and practice. The concept of near optimality or maximum regret is mathematically fully applicable, but the formal analysis has not been done. For me, these are all problems of partial identification. All these problems of limited validity, questions where you have identification problems. So there's just an enormous amount of work to be done to extend things from classical trials to observational data and trials with imperfect validity. Okay, second area for future work. It's not just one trial. You may have multiple trials, and you may also have observational data. The clinician needs to try to bring this all together. So I think, I'm assuming everybody on this call knows about the huge literature on meta-analysis that tries to do that. I will say separately, because this would be an entirely different seminar, I've been hypercritical of traditional meta-analysis done in biostatistics. Hypercritical in general, and super hypercritical of the random coefficients model of Jussimonian and Laird, which kind of dominates the literature. Now this is not just in talk, I'll give an advertisement for myself. I published a solo paper in the journal Epidemiology. So it's my first paper in an epidemiology journal on just in spring 2020 with the title something about towards patient-centered meta-analysis. And it really it explains why I'm so critical of traditional meta-analysis and how I think it should be done. I think some of that work can be brought to bear here for decision-making, but I don't do that in that paper, okay? Finally, is the issue that we talked about before, which I think is the first two issues on this slide, I think I know how to do in principle. It's just a question of doing the analysis. This last thing that I've just highlighted is the one that Alex and I, it really bugs us most, because we need to figure out how conceptually to set this up, is to embed this all in a dynamic framework where it's not just that you got certain information, you're going to make treatment decisions, but new information is going to keep coming in, and you want to set up the whole process for incorporating new information as it comes in, and also to recognize something which isn't on the slide, but which Alex and I are worried about, is that every time you set something up, whatever mechanism you set up, like the FDA or so on, is providing incentives for how new trials and new conducted and how new observational data is collected. And so there's this huge dynamic process in the background. So this goes so far beyond this particular paper. So the last thing I say here is that even if you don't like what we're talking about at all, even if you want to continue doing hypothesis testing, you got to realize that if you're going to do hypothesis testing, then eventually standard care is going to be overturned, and then there'll be a new null hypothesis, and you're going to have a sequence of null hypotheses over time as evidence accumulates. And what we want to do is to try to figure out what the result over time of that's going to be. And I don't have a clue, how to do that. This is very different from a dynamic treatment regime kind of. I know the literature on dynamic treatment regimes. This is kind of a much higher level dynamic problem. So, so these are like 100 years of future research, I think. And I will, as I say in the slides, There's a whole set of slides on the technical appendix. I never expected we'd have time to go through that, but you can either look at the slides or I sent a link to the paper, which is on medRxiv, so you can read all the math if you want.
So,
Okay.
Chuck, can you make the slides available to us?
Yeah, I already sent it to Brian.
Okay, perfect.
Yesterday. There's a slight modification in these slides for that, but the ones I sent yesterday are fine. Yeah.
All right. So I was just Googling around whether or not there's a loss function kind of way of thinking about confidence intervals or confidence sets. So I found some links to some work by George Casella. And then I'm also curious, and also there's another paper about decision-making with confidence sets. I wonder whether or not there's any connection or any extension that could be addressed.
No, not that I found. The name, I mean, Casella's work, I think I remember Larry Brown wrote about this in the 1980s and 90s.
Sure.
I mean, so these are Casella and Brown, who are statisticians who have statistical decision theory backgrounds. And I think they really strained, you know, it was like you want the shortest interval, but why do you want the shortest interval? Well, you want an interval with certain characteristics. I always found those, they were well-intentioned attempts, but they weren't really, they weren't derived from a real-world decision problem. And the stuff that I know, maybe the stuff I missed, you know, Casella and Larry Brown, people like that, they're good people. They were kind of artificial decision problems, at least as far as I know. So because I would have.
The other question I had was, you know, you were very, I understand your concern about Bayes and you know, priors. Do you have a view about empirical Bayes?
You know, I've gone back and read Robbins' 1954, I think, is that the original?
Yeah, Robbins.
I've gone back. It's a little bit like I feel about confidence intervals, that it makes some intuitive sense to me, but from other perspectives, it doesn't make sense. I know some people feel very strongly about. I mean, the kind of things that I have very, very strong views is whenever someone says they're using a so-called non-informative prior, whether it's a uniform prior or something else, then I go crazy. And not just me, because everybody knows that if you take a monotone nonlinear transformation, non-informative just goes out the window. Empirical Bayes is a more subtle idea that seems to go in and out of the statistics literature over the past 70 years. And I don't have a clear view on it. It's more like confidence intervals. I'm just not certain.
All right. All right. Well, it's 1 o'clock Eastern, I guess. So are there any particular questions in the chat? People can, you know, unmute. You can also tune out. It's up to you. I'll hang on for a little bit longer. Does anyone have a question from the chat?
I have a question. Thank you so much for a wonderful talk, and I'm going to try to study this.
So Chuck, let me introduce you to, this is Ilya Spitzer. Do you guys know each other?
Well, I certainly know Chuck's work.
Yeah, so Ilya is a student of Judea Pearls and did work with Jamie Robbins, and he's on the faculty here at Johns Hopkins in the computer science, but is an amazing researcher in the field of causal inference. So just connecting the two of you.
I know your mentors, but go ahead.
Yeah, I just wanted to understand your very intriguing comment about partial identification, which is something causal people think about a lot, you know, when you have unobserved confounding and selection and various measurement error and problems like that. And I just was wondering if you could speak a little more to that, and whether, you know, the sense in which you think about partial identification is similar, or how it arises in these kinds of problems you've discussed.
Yeah. Well, it's pretty straightforward. In the classical trial that we talked about, first, I mean, if you're doing formal statistical decision theory, you have to set up a state space. It's all the possibilities. So it's like all the possible Bernoulli distributions of this and that. It's a fairly simple state space when you have a randomized trial, because you have a lot of prior information because of random treatment selection. So if we go to a standard observational problem where we don't know much, we mainly have we may know nothing about treatment selection, or we may know partial information. The state space is much bigger because also in the state space is, what was the treatment selection, all the worry in the standard literature about selection bias and so on and on and on. Formally, there's just an awful lot more that you don't know. And so partial identification comes up because as sample size goes, just think about it crudely, as sample size goes to infinity, you're not going to be able to get reduce the uncertainty to zero. The critical difference with anything that's partially identified is the sample size goes to zero, there's going to be, goes to infinity, there's going to be residual uncertainty that you're not going to be able to reduce, get rid of all the uncertainty. What's going to be left asymptotically is all the partial identification problem. Now, in terms of the wall theory, it's totally transparent. If you read, this is where you have to go to the math of Wald. It's just, to me, it's mind-boggling beautiful. Wald is such an abstract mathematician. He was too abstract for his own good, I think, that he just defines, there's no difference between parametric and non-parametric analysis, between partial identification and point identification, between finite sample and asymptotics. The basic mathematical structure of Wald encompasses all of them. And so dealing with partial identification becomes an applied problem of how am I actually, to do maximum regret, you have to solve the maximization problem. And minimax regret's the saddle point problem because you're minimizing the maximum regret. And these mathematical problems become much, much more complex. And the only thing that has held up extending this to partial identification has been the mathematical complexity. And this is particularly an area where computer scientists could help a lot because for some things economists like to get analytical results. Alex's work that I mentioned before with Turo Kitagawa is still point identification, but extends things in some pretty nice ways. But at some point, you're going to have to do computational work. And some of us know some things about computation, but this is what computer science is. So that's the kind of short answer on that. Otherwise, I'd have to go into details of particular partially identified problems.
So the way we would put it is, you're making decisions based on some causal effect or something, and it's not identified. You have bounds on it, and that creates problems potentially, or maybe not if you have a certain framework.
Well,
my point, if you have a framework that doesn't distinguish between point identified and not point identified, it's not clear whether that's a feature or a bug of this theory, basically, because they seem qualitatively different situations.
Look, I've been working on partial identification since 1990. It's basically what I do almost all the time, certainly before Judea started. Certainly the first time I met Judea, he had never heard of the term partial identification. To me, if anyone takes my first year PhD course, point identification is a very simple special case of partial identification where the set reduces to a point. So when I say there's no difference, I just mean that point identification is a special case of partial identification. Everything I do is, obviously not the paper today, but almost everything I do outside of the kind of paper I'm talking about today is partial identification. And sometimes you're lucky and you get point identification. So I don't view them as qualitatively different. I just view partial point identification as a limit case of partial identification. That's the way the econometrics literature looks at it.
I'd like to chime in a little. One feature for treatment choice that generally comes up when you have partial identification is with point identification, you tend to have decision rules that are all or nothing. So you pick a treatment. With partial identification, in the work that Chuck has done, and I think Jörg has done, much more often you get rules that are fractional. So where you basically you end up with data where you do not assign one treatment, you randomize between treatments. So I think that's kind of one fairly general feature of how things change when you are in partially identified situation in the treatment choice problem.
Yeah,
from Minimax regret perspective.
Yeah, the thing to add to what Alex said, when I said I don't know how to do this with partial identification, the math, it means with finite sample data. The papers of mine and of Jörg Steuer Jörg aside, because he did do some finite sample stuff. Paper of mine that Alex is referring to is a 2009 paper that focuses purely on the partial identification problem and assumes that there's no finite sample problem. Then you get this fractional treatment allocation, randomizing across patients. And that's a very simple analytical result. The hard problem is to put the partial identification together with finite sample problem. And there's only one paper that I know in my in the econometrics literature that does that, and that's by Jorg in Journal of Econometrics in 2012. So that's not a paper that I mentioned before. So that has both partial identification and finite sample minimax regret. I think it's quite a beautiful paper that is hardly cited at all. It just deserves incredible amount of recognition, but there aren't many people who work on this stuff, so they don't know the paper.
Alex, can you put that paper? Alex, can you put that paper in the chat, please?
Yeah, give me 1 minute.
No problem. I apologize.
If there's stuff, Ilya, and if there's stuff that you and Judea and other people in computer science has been doing that we don't know about, then of course I want to know about them. There's been a bad, communication between computer science and econometrics is not always so good, to put it neutrally. So sometimes things get published in different places, may use different notation, and sometimes so.
Yeah, and Judea is really going after economists these days on Twitter.
Yeah, he hasn't gone after me, but
yeah,
he's busy enough.
Any other questions from the gallery?
Yeah, I did have a question. This is Jonathan Chipman here, and I was just curious if there are any thoughts or guidance on if you were to design an empirical success study, what the operating characteristics would be that would be considered desirable, and if those operating characteristics in some way generalize for multi-arm trials as well.
Yeah. Okay, so this this is a crucial part of the 2016 PNAS paper, because that was on choosing sample size. And we said we don't want to do power calculations. So of course, a bigger sample size is better, no matter how you do it. But how are we going to pick the sample size if you don't do power calculations? So we said, well, let's choose sample size to get maximum regret, to get the closest to optimality down to some level. So in terms of the operating characteristics of what would be acceptable, then how are we going to choose that? At this point, Alex and I said, well, we can do the math and say that if you use this, bigger sample size, then maximum regret is going to go to 0, and we can give you the actual calculations. But then there's going to be a question that the clinicians, that the medical people substantively have to answer is, so how close to optimal is close enough, okay? And so what we decided is that as methodologists, we can't make that decision. So we provide the formulas. Some of it is mathematical formulas for the bounds from large deviations theory. Some of it is tables for the binary outcomes where you have exact analysis. And then we leave it to the clinician or the medical researchers to decide what operating characteristics they want. Now, when we did that, we said, well, how is it done now? Well, I talked about power calculations, but as everybody knows, you can't just do a power calculation. You have to decide what's a minimum clinically important difference, right? Because the alternative hypothesis in a standard hypothesis testing is never a point alternative. It's always a composite alternative. And so medical researchers have always had to make decisions on what's a minimum clinically important difference. What Alex and I, and that has to come from that's sort of an interest to optimality. What's so small that we don't care about? And if you go read the write-up on any clinical trial, then they will say that for this trial, we've, based on our medical judgment, decided this is the minimum clinically important difference. What Alex and I did in our 2016 paper is we gave a kind of algorithm for translating a minimum clinically important difference and an error probability into a maximum regret so that a clinician could do that. Mm-hmm. So I think we have conceptualized in a way that we feel comfortable as to how that should be done, but we don't think it's our decision to make as methodologists. And it wouldn't be a biostatistician's decision to make. It'd be the medical people who are doing clinical decision making. It has got to be their decision. Does that answer the question?
Yeah, that does. You could have like a maximum regret curve across sample size, and
Right.
and clinicians could kind of find their comfort level and balance their cost level.
Exactly.
Mhm.
Yeah. Now,
Yeah.
you raised the cost, since you raised that, because again, I say we could go up, and I know we're well past the 1 o'clock time. The way that this is done now in the standard literature, let's say with power calculations, pays no attention to cost at all. That's okay. Now, and I don't even know how you would do it with power calculations. We can, now in our 2016 paper, we didn't put cost in, but we could easily add cost into the welfare function and say, because everyone designing a trial has cost in the background. Of a larger trial costs more. And so you can take the benefits and patient outcomes, the cost is that it costs more to run the trial. And you do basically benefit cost analysis. So the setup, the near optimality and empirical successful, all that stuff, it allows you to formally embed cost into it. We didn't do that in the 2016 paper, but that's a very simple extension.
Nice. Thank you.
Alex, do you have anything since I've been doing?
Yeah, so I think earlier on I had some discussion in chat on related issues. So one of the things with cost benefit, so kind of economists like to calculate things that they say are optimal in some sense. And of course that comes with a lot of assumptions about, so I think kind of any analysis of what's the right trial size, for example, for COVID, like one of the things that matters is basically how many patients there will be in the future, right? So like that's one of the probably important inputs in sort of where you want to stop studying something and start using the results. Of course, I think in practice with the epidemic, we've seen firsthand how completely unpredictable this is, and how, you know, how wrong we would be if we would have said, you know, 300 is the right number of patients because there will only be, you know, 5,000 patients who have COVID and are hospitalized in the world.
Okay. Well, anything else?
I mean, this is great, giving us a lot to think about, different perspective than we're used to seeing in many of our talks. And so we may reach out to you again for, well, individuals in this group may reach out to you for additional input, or maybe we'll invite you guys back if you're interested, talk about some other issues that have come up as we learn more about your approach to decision making and to partial identification.
Okay.
So I want to thank you on behalf of Johns Hopkins Causal Inference Group. I see there's some people from the University of Utah here, so I'm excited they joined, and then for people joining from Germany. So I really appreciate your time today.
Thank you very much. It was very interesting, and thanks for a lot of questions.
Yeah.
My daughter would do. She's always like snapping when she's happy about something. Like when Obama gave his talk last night, she was snapping. Yeah. So.
Okay. Good to see you.
Chuck, it wasn't as good as Barack Obama. I'm sorry. But
that's a standard. That's okay.
Okay. Anyway.
Thank you, everybody. Thank you, George.
Thank you, Brian, for organizing everything.
Thanks all.
Thank you.
Bye-bye.
Bye-bye.